So now let's move on to the psychological component of stress, now that we've covered the physiological effects of cortisol. Clearly impacted by endocrinologic mechanisms in cortisol and other hormones, the interpretation of stress mentally as a result of CRH and spreading activation clearly deserves its own discussion. It's easier to consider why we would have emergency systems for when we are thrown off of physical homeostasis, since any damage or insult to our body, good or bad, could inadvertently throw off cellular mechanisms that are going on constantly, leading to some error, which could at least theoretically lead to fatal error or cell death or even tissue death. Medullary adrenal systems and supportive cortical adrenal systems can help get us through those moments effectively with the least damage possible, but psychological stress is more abstract. Certainly, when you are going to sit down for an important exam or when you are going on a first date, risk of cell death and tissue injury is not applicable. So why do we respond with the same endocrine systems? At least one way of thinking about psychological stress is a mechanism by which we can consciously or unconsciously detect threats to our well-being, real or perceived, but maybe more so, threats to our well-being in the future as well. In that important exam, we have judged the exam to be important for some reason. Our stress response may be triggered if we are feeling as though the well-being of our future self is in jeopardy, depending on its outcome. And certainly, the unconscious or subconscious threat that we may not be able to pass on our genes could trigger these systems as well. Further, psychological stress may be always an added component of physical stress that compounds the problem. However, because psychological stress relies in part, at least, on some cognitive perception of the nature of the problem and its relative threat to our current and future selves, psychological stress becomes the primary opportunity from a stress management perspective to blunt and attenuate the stress response to limit the damage of acute and chronic stress. For example, although you may not be able to 100% reduce the stress of having a physical injury, expecting the physical injury and being health literate enough to understand that the injury is temporary and will heal may reduce as much as possible the psychological stress associated. Similarly, an important exam may always be stressful no matter what we do, but with excellent preparation, seeing the exam coming from a long ways away and with reframing of the event as an opportunity rather than a barrier may be enough to blunt the intensity of the endocrine response to the event, such that 1, you may feel less negative emotion towards the experience and experience less suffering as a result of the effects of the endocrine pathways, but second, that you may be even able to perform better during the event as a result of achieving optimal arousal, as we'll discuss via the Yerkes-Dodson Law. We know of the physiological responses to stress in the sympathoadrenal pathway, the SAM pathway, and the important supportive HPA axis pathway, but the psychological response has been thought to have 2 components as well. First, the primary appraisal of stress, which is a conscious or subconscious recognition that something is a threat, followed by a judgment of how severe the threat is, and then the secondary appraisal of threat is action-oriented. And so think about secondary appraisal as asking ourselves, what should we do about this? Some in the psychology sphere have coined distress, referring to stress causing negative emotions, and eustress causing positive emotions like exercising. But remember, as we've discussed, these are not categorical terms such that a stress can always be attributed as distress or eustress. To some extent, we personally decide by primary appraisal if a stressor is distressful or eustressful, i.e., exercise may be distressing if you are very encumbered by your lack of fitness and have felt the threat of lack of well-being associated. As a clinician, perhaps we should consider most stressors as potentially neutral until you've assessed individually the effect it has on your patient, such to better identify opportunities for stress management rather than assuming stress is positive or negative. In some ways, the emotion a stressor elicits simply tells us how severe the secondary psychological stress component will be. All stressors throw us off homeostasis. Distressful events may do so more dramatically and have the opportunity to be attenuated by a modified perspective of the stressor. It's important, however, not to build into your practice the assumption that stress must be reduced at all costs. In fact, anyone knows if they've performed in a sporting event, for example, that there is some appropriate amount of stress that allows you to be vigilant and stimulated enough to perform at your best whilst minimally inflicting the damages of the HPA axis and SNS stimulation. In part, therefore, this has to do with achieving 1, a proper intensity of stress, which may be controllable in some scenarios by psychological attenuation, but second by duration of stress, which as well may be controllable, but this may be more difficult. It is probably the duration of stress which inflicts more damages from the HPA axis perspective, i.e. leading to weight changes, susceptibility to viral infections, mood lability, insulin resistance, and so on, whereas intensity of stress can cause dramatic damage more from an SNS perspective, i.e. the death of a loved one, causing a sympathetic surge, which can lead to tachycardia, hypertension, potentially exacerbating cardiac ischemia, and leading to death itself. In addition to the psychiatric effects of high cortisol for long periods of time, i.e. which are things like anhedonia or the loss of pleasure in things, a feature of depression, there are behavioral modifications that occur to patients who experience high loads of stress for long periods of time. Naturally, as you'd expect, the adaptation to feeling like your well-being is constantly threatened can be varied and extreme and partially interface with one's nurture and upbringing, i.e. learned helplessness, if a shift towards a external locus of controlling feel of the stressors are not modifiable, unfortunately, which can lead to the vicious cycle of the disease, where you can think of chronic stress functionally as an endocrine or psychiatric disease, limiting one's ability to treat the disease, but also some specific psychiatric illnesses depending on the nature of the stress. So, i.e., very intense acute stress can lead to acute stress disorder, and if it persists, it can become post-traumatic stress disorder, usually triggered by catastrophic stressors. Even with treatment of the cause of the initial stress, which may or may not be present anymore, patients can be left with permanently damaged associations which become new niduses of stress, and unfortunately these as well need to be addressed and managed. They may be incompletely reducible. Some stress management techniques and strategies offered in the psychology sphere center around attempting to combat the effects of the constantly activated HPA axis and SAM axis by counterbalancing them with deliberate meditative efforts, i.e. with aerobic exercise, which is obviously distracting as it is being aerobically difficult, but may also improve endogenous neurotransmitter release like serotonin and endorphins, which may temporarily or consistently combat the opposite effects of high cortisol. But other things like relaxation or meditation may achieve the same effect, but we begin to see the problem. But they are counterbalancing the effects of chronic stress, but not addressing the root cause to reduce the stress from its source. Spirituality may be able to distract as well, but may even directly reduce the SAM drive and reduce the incoming stress load by creating a built-in reframing process that can put into context the chronic stress in the scope of one's life and perhaps their life after death. It has been shown, however poor methodologically from a cross-sectional study perspective, that people living in blue zones who have longer than average life expectancies often are more commonly spiritual or religious in those communities. If nothing else, think of the advantage from a chronic stress perspective that people have if they are able to put into perspective their suffering in the context of their shared community and the shared suffering of others, but also in the context of a potential afterlife or a more focused view of their purpose during their life. Even if our patients are not spiritual, understanding how spirituality and religion may help reduce the suffering of patients through stress management may give us ideas on how to attack it as well. Now let's move on to talk about emotions. And emotions are of course relevant to stress since they reflect our subjective experiences, which are voluntary or involuntary, to internal or external stimuli. As such, emotions may reflect a conscious component to experiencing distress or eustress, or may be clues that we are experiencing distress or eustress even if unconscious or subconsciously. There are importantly three components to emotion: the physiological component, which is the body's physical response, the cognitive component, as well as the behavioral component. Charles Darwin, in fact, theorized on the role of emotion, specifically coining the adaptive role of emotion, the thought that those who could express emotion visibly would be better suited to survive and reproduce, such as the ability to show that you need assistance when you're sad or when you're aggressive. As a result, universal emotions have been theorized that all humans should be able to recognize just on inspection of someone's facial expressions, seen here to the left. And the 6 universal emotions are fear, anger, sadness, happiness, and then the 2 other ones are surprise and disgust. In fact, the inability to identify these emotions can be possibly recognized as a psychological disorder. But are emotions primary, i.e. we feel emotion involuntarily, then analyze it second, or is emotion secondary, i.e. is emotion applied after some psychological process, partially cognitive and conscious? As with all, the truth is likely both, i.e. we know that sometimes we can make ourselves feel better, and thus emotion is partially cognitively driven, but sometimes it is an involuntary operation. But how do we encode and then experience emotions physiologically? There are four main theories on how we do this and in what order of operation. So let's make each of them very clear and easy to remember. Think of James Lange theory as body first, and it was invented in the 1880s in the USA and Denmark. Essentially, that the body and the thought process of an emotion occur first, and then you have the emotion subsequently. Cannon-Bard theory, I think of in Cannon, the body and the thought, so physiological response and cognitive response happen simultaneously at the same time, but independent of each other. Schachter-Singer theory from 1962 is called two-factor theory, which is not a good word, but essentially that emotion comes from the cognitive interpretation of your physiology. And then Lazarus theory, the latest one in 1991, is really just Lazarus labeling. Lazarus labeling that emotion is not possible until its experience has been labeled by your cognition. Although our neuroanatomical understanding of emotion and stress is very limited, we have a basic understanding that the limbic system is involved in the processing and generation of emotional responses, at least to some degree. The limbic system actually refers to a collection of anatomical structures located in various brain regions, each with probably a somewhat distinct function. The amygdala is an important component of the deep temporal lobe that conducts our experiences and emotions with the hypothalamus. The amygdala seems to be important, specifically maybe for fear and aggression, and our hypothalamus obviously controls the CRH as a result of stress. The thalamus is also a component of the limbic system and is of course our sensory relay, while the hippocampus, a memory center, helps encode emotions in the temporal lobe that we associate specifically with memories, and why PTSD may involve flashbacks. Other structures like the prefrontal cortex are of course a part of the limbic system and being responsible for executive function and decision-making with regards to stress and inhibition of impulses, but realize that many other structures such as the insular gyrus, which might be related to empathy, and the cingulate gyrus related to pain may also be involved in the limbic system. The stress disorders listed in the DSM-5, for what that reference is worth, refer really only to acute stress, i.e. the effects of a very traumatic or catastrophic event that exerts an extreme stress load on an individual suddenly, i.e. hyperintense activation of the SAM and HPA axis, usually because of a severe threat to life or severe actual injury, combat-related trauma, sexual assault, dramatic interpersonal conflicts, child abuse, or severe medical illness. Therefore, this is distinct from the probably more pervasive type of stress-related problem, which would be an elevated stress load in duration comparatively to the rest of the population, i.e. plus minus more intensity, but patients experiencing more stress over more time in their life, which does not have a medical diagnosis attached to it or chronic stress disorder. Acute stressors therefore have a distinct pathophysiology, and knowing what we know about acute stress and the activation of these endocrine pathways, we can appreciate that what really is happening here after exposure to a traumatic event is semi-permanent physiologic and psychologic adaptations to a hyperintense SAM or HPA axis activation. Physiologically speaking, some in the sphere suggest that elevated baseline CRH occurs, which creates a basally increased SAM activation and therefore sympathetic tone, as well as decreased, perhaps from feedback, GABAergic activity or stimulation, which allows free increases in glutamate, which could explain symptoms of derealization and dissociation. In addition, some have considered low serotonin levels and an altered connection between the amygdala and hippocampus and the prefrontal cortex, removing some conscious control of emotion. These are, however, speculative. Psychologically speaking, however, the pathophysiology is less described. However, it is not too difficult to speculate. From a psychological perspective, since stress is experienced with a threat to homeostasis or future self well-being or homeostasis, an intensely traumatic event not only threatens well-being now, but can disturb the perception and cognitive evaluation of current and future self-safety and homeostasis. Throughout our whole lives, we not only create a scaffolding of understanding of how the world works, but then continually update it in a way that helps us understand the likelihood of threat to our lives and how we can interact with each other and the world safely and sustainably long term. When something truly traumatic happens, whether justifiable or not, it is easy to speculate that we may have to consciously or unconsciously wrestle with a direct contradiction to our preconceived notions of how the world works, which can temporarily or possibly permanently disrupt our ability to threat assess, i.e., the psychological primary appraisal component of stress. We may feel so psychologically betrayed by the harsh contrast between our pre-existing schema and the trauma we've experienced that recovery into a steady state of congruent assessment of the daily threat to our lives could be protracted. Think of it as both the cognitive component of stress and the physiological component, endocrine axes, being broken in need of rebuilding and repair. I think discussing and hypothesizing this psychological mechanism is not only interesting but actually mandatory for an appropriate treatment approach to traumatic stress disorders. We must recognize that patients are fighting with a disturbed sense of reality and truth, reorienting them to the safety of their surroundings without ignoring the reality of their trauma, and understanding that depending on its severity, time may be the primary factor in eventual recalibration. Kindness and empathy is helpful, but those who are unable to communicate their emotions and experiences with others are less likely to recalibrate and may do so in a very protracted manner. An advisable approach should be making it clear that there are people to talk to, and perhaps even if the patient is not interested in doing so, slowly and caringly drawing from them over time in a deliberate way, which could expedite the process and limit morbidity. Of course, there are other stress-related disorders other than acute stress and post-traumatic stress disorder. For example, adjustment disorder, which is really the trouble with adjusting to a new life scenario, common with termination of a relationship or moving, for example. Whereas there are also some other diagnoses that are specific to pediatrics, such as reactive attachment disorder, which is related to a developmentally disturbed and inappropriate attachment behavior, such as a child refusing to touch or having no remorse or regret and being unaffected when left alone. Whereas another diagnosis called disinhibited social engagement disorder, where a child may be overly comfortable with or familiar with relative strangers, possibly due to social neglect. There are also other less described diagnoses in the DSM-5 that may be characteristic of stress, but once again remember that acute stress is not the only type of problem that humans experience on a daily basis, and in fact, chronic stress, even if not directly a psychological disorder, might contribute indirectly to other sorts of organic medical diseases. As I'm writing this, I am well aware from an internal medicine perspective that no attempt is made routinely to estimate the amount of stress that a patient is chronically or longitudinally under during their life. I understand the limitations, being that the evidence base is small for providing actionable management strategies that provide some rock-solid measurable benefit, and further that stress is fluid and comes potentially in waves for people, changing throughout their lives in an unpredictable fashion, and as such, estimation would be a snapshot at the moment and potentially difficult to address. But I'd simultaneously argue that those criticisms are applicable to most diagnostic testing, i.e., a snapshot in time where it is dynamic, and often diagnostic tests give us some gestalt that there is something wrong that requires some further examination or testing. We take limited social histories in practice to estimate the effect of some social consequences on our patient's health because we are clinically aware, even from a common sense perspective, that there are multifactorial risk factors at play when it comes to whether or not our patients develop illness or die from illness. Ignoring an entire component that has been shown to increase risk for disease, specifically cardiovascular disease, obesity, addiction, and mood disorders most strongly, seems egregious. But I think more importantly that these things that are contributing to chronic stress are often things that can be directly addressed and managed. Very often, we deal with problems in medicine that seem like there is very few available permanent solutions. In the case of chronic stress, if something related to a job or a living situation, for example, is contributory, they may very well be completely remediable. And missing the opportunity to do so in allopathic medicine is unfortunate. Although we have allied health professionals who theoretically contribute to this gestalt, there are none who focus specifically on chronic stress, and further, none who would be trained or able to connect that piece to the medical gestalt of the patient that a primary care physician would. I would propose that perhaps we should follow along even with snapshots of a patient's estimated stress load, even if subjective per patient report, as perceived stress may present an even better opportunity for management, just like we would for any other chronic disease, with some attempt for deliberate management as a component of a holistic approach to disease management and prevention. If no one else, a patient's doctor should be an advocate for their well-being, and most can make some improvements to their well-being, especially when under higher lifetime stress loads than others may be. Now let's try some practice questions specifically to emphasize what we've got so far for stress psychology. Physiological arousal can serve to improve or impair individual performance on certain tasks depending on the extent of arousal and the nature of the task. Researchers investigate the effect of physiological arousal on memory. A memory recognition task was implemented in which study participants were initially presented with 30 different words on a computer screen. Later, participants were presented with another 30 words and asked to identify if each word was or was not present in the initial stage. Many of the words presented in the later stage were similar to the initial words. For example, the word walkway could appear in the initial stage, while a related word, crosswalk, could appear in the later stage. However, several words were repeated without alteration from the initial stage. In the experimental condition, participants were presented with the initial 30 words, then led down a hallway. In this hallway, an actor purposefully intimidated the study participants by leaping around the approaching corner. The participant was immediately directed into another room and given the recognition task. This is a silly experiment. In the control condition, participants were taken down the same hallway and into the other room without being surprised. All study participants were given a heart rate monitor to wear for the duration of the study. The number of errors committed on the recognition task by each participant is shown in figure 1. So here's figure 1 to the right. We have our control group and our experimental group. Our experimental group was scared before they did the second recognition task, and our control group was not scared. You can see that the change in heart rate was essentially minimal, around 10 beats per minute, no intense change of heart rate, and the number of errors stayed relatively low, whereas in the experimental group, we had a big change in heart rate up to 40 beats per minute, and the number of errors went up as the number of as the heart rate change actually went up. But we actually see that instead, first there is a little bit of a dip in the number of errors. So the improved, if they had a small change in heart rate, they actually had an improved rate of errors, and then after a certain, they actually had a much worse outcome later on. So for our practice questions, question 1, which brain structure was most closely associated with participants' immediate response to surprise in the experimental condition? Was it the prefrontal cortex, thalamus, amygdala, or hippocampus? Of course, we don't actually know which one was the most responsive. That would require a functional MRI or some sort of imaging technique, but we generally understand that the limbic system was stimulated as a result of being scared or surprised, and the amygdala, of course, is one of our most important organs that we're familiar of being responsible specifically for fear. Question 2, in this study, the dependent variable is what? The number of errors committed, change in heart rate, surprise attack, or physiological arousal. Remember that the dependent variable is the one that you do not manipulate in the study, and you're actually looking to see for its results. So in this particular case, the number of errors committed was what we were interested in as a result of scaring the participants. So scaring, or the surprise attack, was the independent variable, and the dependent variable was the number of errors committed, which is the result of the independent. Question 3, the trend in the data from the experimental condition can be best explained by which phenomenon? Is it Cannon-Barth theory, Yerkes-Dodson law, endocrine response, or learned helplessness? Hopefully recognize that in the experimental arm, there's actually an improvement in errors committed with some increase in heart rate, but then a falling off if it got too high. So that optimal arousal zone is known as, of course, as the Yerkes-Dodson law. Cannon-Barth theory is when physiological experience and cognitive experience of an emotion happen simultaneously, and learned helplessness is as a result of, over a long period of time, chronic stress and anxiety. You can shift to an external locus of control. Question 4, which physiological response were participants least likely to have after the surprise in the experimental conditions? Was it muscle fatigue, perspiration, decreased digestion, or increased blood flow? Hopefully you recognize that, of course, these patients or these people should have experienced a sympathetic surge from the SAM pathway as the dominant pathway that's happening here. So really this question is asking which is not a feature of a sympathomimetic pathway. And so of course muscle fatigue is not normal to have as a result of an adrenaline spike. In fact, you'd have the opposite, feeling like you are a bit stronger, more able to approach a scary scenario like that. And question 5, suppose researchers conducted another experimental condition where participants were led in brief meditative exercises that lowered their heart rates before completing the final stage of the recognition task. Under this condition, participants were found to make more errors on average than control participants. How would this new data affect the results of the study? So try for yourself first. Hopefully you recognize, of course, that we're talking about the Yerkes-Dodson Law here, and so if it was true that when we lowered patients' heart rates that their performance worsened, this actually supports what we already saw in the experimental arm, which is that to some degree it improves when you increase heart rate, but then it starts to fall off afterwards. And so the answer here would be B, that this actually supports the further away from optimal arousal, the more errors will occur. And our final practice questions. Question 1, which of the following is not a component of emotion? Cognitive, physiological, psychological, or behavioral? At least semantically speaking, this is a memorization question. Remember that there's no such thing as the psychological component of emotion. The psychological component of the emotion is the conglomerate of cognitive, physiological, and behavioral. Question 2, which hormone is released during the body's endocrine response to stress? Is it testosterone, insulin, aldosterone, and norepinephrine? Well, in reality, actually, it's probably more complicated than this question is making it sound. Hopefully you just recognize right away that norepinephrine is the right SAM pathway hormone, and we don't see cortisol here, which would also be a correct answer. But in truth, when you secrete CRH as a result of stress, you probably secrete some aldosterone as well. So again, this is sort of a bad question, but hopefully you recognize norepinephrine is the best answer here. Question 3, which theory of emotion is also known as the two-factor theory? Is it Schachter-Singer, Cannon-Bard, James Lange, or Yerkes-Dodson? Remember that Schachter-Singer is, of course, the two-factor theory that essentially emotion is a result of the cognitive interpretation of the physiological response. Cannon-Bard is that physiological and cognition happen simultaneously but independently, and James Lange theory is that physiology comes first as well as then cognition, and then you experience an emotion, whereas the Yerkes-Dodson law is the optimal arousal theory, and the Lazarus theory is that you cannot have an emotion until an experience has been labeled by your cognition. Question 4, a camper opens her tendencies of bear, rummaging through her belongings. The camper's evaluation of the threat that the bear poses is part of what? Hopefully you remember, of course, that your threat appraisal and how severe the threat is and recognizing the threat in the first place is your primary appraisal. Secondary appraisal is you're deciding what to do about it, right? Question 5, and our last question, is anhedonia is best described as what? A lack of motivation, trouble falling asleep, feeling a lack of control, or diminished ability to experience pleasure. Hopefully, of course, you remember anhedonia simply is a diminished ability to experience pleasure, characteristic of stress, of course, of acute stress, but also of chronic depression.